So let's look at how this compares to medication. These are a couple of the common medications that you'll hear talked about in terms of treatment. These are atypical antipsychotics, kind of like the mid-level of treatment. Usually you'd start with something like clonidine or guanfacine. If that doesn't work, then you try to go to an atypical like Risperdal, something like that. We wanted to look at, what's that? Yeah. We compared CBIT to the CBIT trial. The child study got published in the Journal of American Medical Association, and the adult study is coming out shortly in the Archives of General Psychiatry. So those are the two different studies. The sample size for our CBIT trial was 126, and this compared to one of the best risperidone studies was 34 subjects versus 28 subjects for ziprasidone. You can see there are a lot smaller studies when we talk about some of these medication trials. Our control groups, and then we look at how much reduction in tic severity scores did we actually see. CBIT showed a 31% reduction in tic severity scores, 36% reduction for Risperdal, and 35% reduction for ziprasidone. Essentially, we've got a treatment here in terms of amount that it brings tics down that's roughly similar to Risperdal, the atypical antipsychotic, so like the second level of medication that you would try. That seems to be what we have in terms of how much it brings tics down. Now, we also did something unique in that we looked at side effects. So every week we measured the side effects of treatment. Did any of these problems crop up for you in the last week? And what we found, and I have 4 highlighted in yellow here, what we found was that there were no differential side effects in the 2 treatments. So the treatment where we were teaching them to control their tics was no different in terms of side effects created than the treatment where we didn't ask them to do that. All right? And the 4 I have yellow highlighted are those that are there because sometimes in popular press books, sometimes in articles that you find, or sometimes in chat rooms you read on the internet, you'll hear these complaints made about any kind of tic suppression type of treatment. Okay? And sometimes people misunderstand behavior therapy as a tic suppression type of treatment. That behavior therapy will make you more anxious and nervous because you're always trying to focus on your tics and it's making you so upset and uptight about it. And what we found here is A, that was a very rare occurrence, and B, it didn't happen any more in one condition than the other. So there was nothing about behavior therapy that made you more anxious or nervous. That behavior therapy will make you disruptive because you'll feel like you're so ticky you'll just have to kind of get disruptive and angry and aggressive, and that doesn't happen. It'll make your tics worse. The more you pay attention to tics, the more you try to stop your tics, it'll actually make them harder to control. They'll get worse. There's some concern about that. That doesn't happen. And that doesn't happen, and it happens, in fact, even a little bit less in behavior therapy than in the control condition. Right? Tiredness and fatigue. This tic treatment is a very tiring, fatiguing kind of thing, and it's just going to wear you out. Well, the truth is that didn't happen either, and it didn't happen any more in one condition than the other. If anything, it happened a little more in the condition where we didn't try to get them to control their tics. Okay. So we have a treatment that's fairly effective and what appears to be fairly safe. So then the question comes, if behavior therapy for tics is so promising, then why are we just hearing about this as a brand new thing? Why is this such a novel thing when habit reversal, for example, has been around for 40 years now? Why is this for the first time coming out as something like it's new? Well, I think there are a few things. First of all, we have some problems that we have to address as a field. We have to address the issue of dissemination. We have to understand how we're going to teach therapists to do this. That's not necessarily an easy thing to do. It's not like we have drug reps, for example, running around teaching psychologists how to do behavior therapy. That does not exist. There is no good way to get psychologists really well trained to do a therapy. We haven't figured out, we haven't done the research to figure out how to get that to happen yet. And so there's that problem. There's the resource problem. It's not cheap to train one-on-one psychologists over and over and over and over again to try to get them to do this. That's a problem. Drug companies have millions of dollars to push out to get physicians to teach them how to prescribe new medications. And so that training is kind of funded and built in to sell the product. That nobody gets money off making this product. It's just something that's out there and it's got to be picked up. So the TSA has been trying to figure out ways to get therapists to do this and to train them. They're doing it in a couple different ways. There's a partnership the TSA has with the Centers for Disease Control. How many of you have been to one of those talks in your region? Anybody? one of these local TSA talks? I bet you have, actually. But there's that, and that we do a lot of talks for patients. We do a lot of talks for therapists. And what we try to do with the therapist is to teach them that this treatment exists, to teach them that there are effective treatments like this out there. We also, the TSA this year has started something called the Behavior Therapy Training Institute. So is anybody who's been to one of those here? I know there are a couple people floating around. Maybe they didn't come to this session because they just heard it all 2 days ago. But we've had 2 behavior therapy training institutes that people pay to come to. So they pay like $500. We have a 2-day workshop with them where we train them and then do follow-up consultation with them to make sure that they're doing it right. And so far we've had like 50 people come through and do this training. So these are professionals from all over the country who want to learn more about how to do this. And so we're trying to do things that we can to disseminate and get people to know how to do this treatment effectively, but it's really not an easy thing to do. And it's going to be a little while until we can ramp up the number of people who are actually really well trained to do this kind of thing. We also have a referral problem in that the neurologists and pediatricians are usually the first people to get the referrals here. And a lot of times they simply don't know that this exists. And if they do know it exists, they don't know where to go to send patients to get it. And so we've got to do a lot of work here to A, teach them that this exists and that this is a treatment option, and then B, we've got to fill that up with, backfill that with people who are really well trained that they can have access to. There's also a bias, I think, a residual bias. It's diminishing every year, but there's a bias against psychological treatment for Tourette's. Some of the people who are older in the Tourette's community remember that treatment before Haldol, before antipsychotic medication, wasn't a good thing. It was a very kind of dark place for a person with Tourette's in terms of treatment. Good treatment options didn't exist. The treatment options that were out there were often blaming of the parent or the child, and there was a lot of kind of bad vibes coming out of psychological treatment at that time. You know, you go to the psychologist, and the psychologist said, "Oh, it's just a nervous habit. You know, just learn how to relax, and you'll be okay." You know, that's not what we're saying for sure, and that probably wasn't good advice then either. But a lot of people who are older have felt a little mistreated by psychology in some ways in the past, and because there are a lot of psychologists who don't know much about this disorder. So there's some bias against psychological treatment that we have to overcome to get behavior therapy more acceptable, I think. And there's also a few beliefs about the negative effects of behavior therapy. Some people in fact, some physicians actually still write about these negative effects. The truth is there's no data behind the negative effects, but people continue to kind of promulgate the negative effects. Let me give you a couple examples. There are a couple examples of concerns people have about behavior therapy. First is this idea of rebound effects. The idea of rebound effects involves people getting very concerned that if I teach my kid to suppress my tics, and isn't that what behavior therapy does? If I teach my kid to suppress their tics, after they stop suppressing them, their tics are going to return and explode. It's like tics are a steam cauldron, and if I block all the vents, the steam's just going to build up, and then something's going to explode. Okay, there's that idea. All right. There's another idea too, another criticism of behavior therapy, and the criticism goes something like this: behavior therapy really is just, it's like, whack-a-mole. You're sitting there and you hit one mole and another mole pops up, and it's just all you're really doing is chasing. So you bring one tick down, it's just going to make other ticks worse, right? So we wanted to look at these things. We've tried to test both of these ideas. In one study we did, we tried to test a rebound effect. We had 7 kids with Tourette's, and we had them come into our experimental room. We had them sit down in our room, and it's a 3-meter by 3-meter room with observation mirrors on it. And we told them, this little box in front of you, I don't have a picture of it, there's a box about this big. This little box in front of you is a tick detector. It's got motion sensors in it. You see the little camera? It's been programmed to detect just your tics, okay, because we had just done some big interview beforehand. And this machine can count your tics for you, right? Now, we're going to ask you to do some different things. The first thing I'm going to ask you to do, called baseline, is I want you to sit there and feel free to tick. Don't try to stop them. We're going to leave the room. You can tick. The tick detector will be counting you, but that's all, okay? So we leave the kid in the room. We come back in and we say, now this time the tick detector is going to do something a little special. Now I want you for the next 5 minutes to try as hard as you can not to have tics. And for every 10 seconds you go without a tick, you're going to get a little token. The tick detector is going to shoot out a little piece of money for you. All right? It'll be worth a few cents. All right? We're trying to get them to suppress their tics because we want to see whether that makes the tics worse. Then we come back in and we say, okay, for the next 5 minutes, the tick detector is not going to be giving you any money anymore, and we don't want you to stop your tics anymore. We just want you to feel free to tick. All right? So now what we're testing is rebound. Does suppressing your tics make them worse after you stop suppressing? Okay. Here's what happened. In these 7 kids, 50% of the time they were ticking at baseline. They were ticking a lot, right? When we asked them, when we reinforced them for suppressing their tics, gave them money for not having tics for 10-second periods. This isn't treatment, by the way. This is just an experiment. We would never treat a kid like this. This is just an experiment. It dropped to about 15% of the time. We reinforced the suppression of tics, and their tics dropped to 15% of the time. Now, if there's a rebound, if suppressing your tics causes a rebound, what should happen? Go above baseline, not just return to baseline. Return to baseline is normal. You know, that's normal functioning. What happens? Well, it actually doesn't even quite get back up to baseline. And then we ask them to suppress again. What happens? It goes down again, just like it should. And then we look for the rebound. And again, it doesn't happen. In this study, there showed no rebound effect. Now, some people have said, but this is 5 minutes. You know, make them suppress for a long time. What happens then? Well, we did that in a second study. We had kids come in and we had them suppress for 5 minutes, followed by a chance to look at the rebound where they weren't suppressing anymore. We had them suppress for 25 minutes, followed by a 5-minute period where they were allowed to tick if they wanted to, and a 40-minute period of suppression, followed by a 5-minute period where we checked to see if they had rebound. And this is what we found. And they all got all durations. They all had to suppress the same number of times. At baseline, they were ticking about 8.5 times a minute. When they suppressed for 5 minutes, they went down to 2 times a minute. The rebound following that went up a little bit. It looks like it went above baseline, but statistically that's not significant. That was just kind of fluctuation in the data. When they suppressed for 25 minutes, they were able to do that too. What happened after 25 consecutive minutes of suppression? You'd expect the rebound to go even higher because they've been suppressing longer, and it doesn't. In fact, it starts to go back down. When they suppress for 40 straight minutes, they can still do it. And when we look to see what happens after 40 minutes of suppression, that's when you'd expect the rebound to be highest, but it's actually not. In fact, it even goes down a little further. So what do we conclude from this? And these are just 2 of the studies. We've done a number of other studies just like this, and we never find this. We've never found rebound at all. So what we conclude is that there probably just isn't this rebound phenomenon. Now, why do people keep thinking there's a rebound phenomenon? Here's why people keep thinking there's a rebound. Okay? The reason people think there's a rebound is because every parent sees something like this. My kid doesn't tick at all at school. And they must have been holding it in all day at school because they haven't ticked at school. But when they come home, my God, they explode. You know? So they put the logical conclusion together of they've been suppressing their tics all day at school. Why? Because they're not there at school. And then they come home and his tics are much worse. So it must have been because he was suppressing, right? Well, these data say probably not, actually. What's probably happening in this, the home school thing is probably where are all the reinforcers for not having tics? School. Where are none of the reinforcers for not having tics? Home, because you're doing what you should do. You're creating a safe, supportive environment. You don't care if they tick at home. You're not supposed to care if they tick at home. That's the good thing. So what happens? They don't tick at school because the contingencies say don't tick at school. They tick at home because it's okay to tick at home. And so you see that contrast. And that's what you're seeing. And it's easy to interpret that as suppression causes an increase, but it doesn't. Okay? The evidence says that that's not actually happening. Right. What about the symptom substitution idea? To study this, we actually did something interesting. We treated vocal tics in kids. We had 5 kids. We treated their vocal tics, but not their motor tics. And we did that intentionally. Our hypothesis was that if we bring the vocal tics down, then if the symptom substitution hypothesis is true, that really all behavior therapy does is push tics around, then as we bring the vocal tics down, the motor tics should actually increase, right? Because we're bringing down one set of tics, the other set of tics should go up, if the symptom substitution hypothesis is true. So we treated all of the children's vocal tics in one 1-hour session and 2 half-hour booster sessions. We did it on the vertical dashed line. That was the day the 1-hour session happened. Each data point is an in-home videotaped observation of the child. We set a video camera up in their room where the parents said that the child was most likely to tic, and we left them for 20 minutes. We came back, grabbed the videotape, and went out to score it. All right. We did this multiple times a week. And what you find, each panel is a different child. What you find is that for Don, the first kid, you see a significant reduction after treatment in his vocal tics. His motor tics, which we didn't treat, also decreased. And he maintained it 3 months later. John, significant reduction in his vocal tics, no change in his motor tics, and he relapsed 3 months later. Ben, significant reduction in vocal tics, no change in motor tics, maintenance at 3 months. Raul, significant reduction in vocal tics, no change in motor tics, and maintenance at 3 months. And Frank, treatment didn't work for Frank. Okay, so what do we conclude from that? We conclude that this is a treatment that doesn't just push symptoms around. Okay? It's not that you're going to push one set of symptoms down and other symptoms will reemerge as a result of that. Now, that's not to say a kid with Tourette's won't get new tics on behavior therapy, because of course they will. New tics come and go. That's part of the syndrome. New tics will always emerge during any treatment. That's the nature of the disorder. Okay. Habit reversal. In conclusion, habit reversal is a promising treatment for Tourette's. We still need a lot of things. You know, the studies that we've done have been under very tightly controlled conditions in big clinical trials. That might be very different than how this treatment performs out in the real world, so to speak. So we need big studies kind of looking at how does this perform in the real world. We need to understand predictors of response to treatment. You know, does this work as well for kids with ADHD? And it doesn't, actually. Kids with ADHD make everything a little bit tougher to treat from a behavioral perspective. Does it work as well for kids with OCD? Yes, it does. Does it work as well for kids with anxiety disorders? Yes, it does. Does it work as well for kids on tic-reducing medication? Maybe not. And we're going to talk about that as we learn more about it. Not today, but as we learn more about it, we might learn how to medicate children and use medication with this intervention more effectively. How does this work a year out, 2 years out, 3 years out? We have to figure that out. What's actually causing the change here? You know, I've been starting to hear about some neuroscience studies that show that there are some neural changes that are associated with effective response to this treatment. So if you do well in this, something in your brain has changed. And so that's interesting. And that'll be interesting to see how that pans out in the next few years. We also need to overcome barriers to implementation. How do we make sure we get this treatment out to people who can use it? We've done a couple studies looking at whether we can deliver this treatment on telehealth, teleconference equipment, Skype, those kinds of things. And what we're finding is that this actually works pretty well when you use teleconference equipment. So people don't have to travel so far to get some of these things if the right equipment's in place. Looking at developing computerized therapist training packages, educating appropriate care providers about behavior therapy. Ron. Before we wrap up, I want to go over a few things that I want to make sure you hear out of this talk. The few things that I'd like you to take home from this. Actually, there are things I don't want you to take home from this, because I always get scared when I do a talk like this to parents because I don't want them to misunderstand what I'm saying. So a couple things. First, I'm not saying in this talk that all children with tics need or could benefit from behavior therapy. Okay? A lot of the kids that I see, I won't treat, even with behavior therapy, because the tics aren't a problem for them. The moms and dads are seeing a tic that looks bizarre, they're nervous, the kid doesn't want help, the kid is fine socially, everything's good. All they really need is some education about this, and they need to know that they're doing the right thing, and that all they need to do is just let the tics go, and they'll probably take care of themselves. Okay? That's a good way to go still for a lot of people. It's only when the tics are a problem, you know, they're really causing a problem, that we need to think about intervention. The other thing is, we're not saying that because behavior therapy works, Tourette's must be a learned problem or something being done intentionally by the child. Everything you heard me say, you could easily misinterpret as, oh, so you're saying my kid learned how to do this, or I taught them how to do this, or they're trying to do this. No, not at all. I'm not saying that. I'm saying the environment influences the brain, and the brain has a problem with tics, and it's making the brain problem a little bit worse. Okay? But it's not an intentional thing. Behavior therapy for tics sounds extraordinarily simple. It's not. It's hard and it's a lot of work. It's hard for the therapist, it's hard for the kid. The work can pay off, but it is work. I'm not saying that behavior therapy works for everyone. I've said a couple times, if somebody tries to sell you a treatment that works for everybody, there's something wrong, because there is no treatment that works for everybody.